Welcome, everyone. My name is Kate Picot McMullen, and it's my pleasure to be tonight's tech host for the Southwest Harbor Public Library. We are just starting up, and more folks will be joining us as we continue on in a little bit here. But I would love to welcome you and to tonight's event. It's for the Women's History Month, and it's the history of healthcare for women in the U.S. with Linda Robinson, nurse midwife. Happy International Women's Day. Before we begin, I'd like to welcome you to visit the library in person to see the Women's History Month community exhibit pieces created by over 30 women and girls connected to Mount Desert Island. The theme this year is Women Providing Healing, Promoting Hope. I say it each year, but yet again, this is an incredible show in the breadth of the creations, from weavings and sculpture to photography, musical compositions, and a digital photo essay, to the deeply meaningful exhibitor statements for each piece. Please also visit the Women's History Month exhibits at the Bass Harbor Memorial Library, Northeast Harbor Library, and the Jessup Memorial Library in Bar Harbor. In addition to tonight's program, the library will be hosting another Women's History Month program later this month, Encouraging Healthy Relationships, a discussion facilitated by Taylor Roos, the Community Sexual Violence Prevention Educator for the Aroostook Mental Health Center Sexual Assault Services. This program will be, there's the exhibit. This program will be 2 weeks from tonight on March 22nd at 5:30, also online. And you can register for those at our website. I strongly encourage all of you to reach out to teens and adults you may know to join us in 2 weeks. This is an important conversation where we'll examine the behaviors in a variety of interpersonal relationships, discuss where our personal definitions of healthy and unhealthy come from, and guide you to consider how to cultivate practices that feel healthy in your own relationships. I'll put our website in the chat so that you can go do that quickly. A few administrative details. Please mute yourself during the presentation, and to help with a better view of this program, set your view to speaker view, and that should help see most of what we want to present to you. I will also be facilitating the question and answer at the end of Linda's presentation. And to participate in the Q&A, type your question in the chat or raise your hand with the little symbol down below, and I'll acknowledge you. If you've got a burning question, go ahead and put it in the chat, and we'll see if we can fit it in if things happen during the presentation, but the end would be great as well. Well, without further ado, please welcome Ms. Susan Buell, one of our Women's History Month committee leaders, who will introduce tonight's guest, Linda Robinson. Welcome, Susan.
Hey there, and I don't know where I am here.
Here you are. There you go.
Okay. Anyway, hello everyone, and I'm so glad that you're here. Linda Robinson is an incredible person, is all I can say. But I do want to, today's is International Women's Day, and it's a perfect timing for us to host Linda Robinson, because her interests and passions and experiences revolving around women's health are really, truly international in their scope. Linda was a Peace Corps volunteer in Malawi right after her nursing school. With her husband and children, years later, they went to America, Samoa, where Linda set up the first midwifery practice there. And most recently, Linda was a teaching midwife in a remote and very impoverished community in the Democratic Republic of Congo. As she has said another interview, there was not anyone there that she met as a patient or a team member that hadn't witnessed someone being killed. I mean, this is an area that had been devastated by violence. Linda is also one of the founders of the Women's Health Center in Bar Harbor, for women and by women. And she was there for 23 years. You would think with all this work would be enough, but it is not enough. And Linda continues to advocate for the best outcomes for women, for fair, respectful healthcare for women. She's taught at COA, and I had a good experience to have a class with her through the Acadia Senior College as well. She has taught us about, well, and you can read this in the paper or, you know, in the media as well, that our outcomes, our maternal outcomes in this country are abysmal. They're among the worst of, if not the worst of the developed world, of the wealthy countries. And our cesareans for birth are much, much, much greater than other, again, wealthy countries. Linda has authored the book about the Congo. Her Congo experience is called Sunday Mornings in Shamwana. I've not read it, but now that I read about it, I will be reading it, and maybe we have it at the library. I hope so. Linda has also authored 2 other books, one called Being Pregnant, and the other is Women's Sexual Health. In her almost 40 years of practicing with nursing, Linda has seen how money, power, and convenience, quote, have limited women's choices. And she's also been talking about what is informed consent. If you don't have the whole story, don't have the pros and cons of whatever decisions about your own healthcare that you need to be making. So without further ado, I introduce Linda Robinson, and I'm really looking forward to this talk. Thank you.
Oh, thank you so much. I appreciate this invitation tremendously. I feel very passionate, obviously, about caring for women. And there have been so many changes in the way we deliver healthcare to women throughout my career, certainly. And I spent a lot of time wondering, especially over the years, wondering, how did we get to this place? How has it come to this where we feel like we're making strides forward and then we have all these, slides backward? And one of the ways that we can bring some of those questions into clarity is studying the history of women's healthcare and how we got to where we are. So I taught this as a 10-week course, so I struggled to distill this into a 35-minute presentation. And I don't want it to be a fire hose of facts, but I want to give you a timeline of how we got to where we are now. I'm going to share my screen and go through this presentation. I completely understand that this is not completely comprehensive. I mean, there's many different directions we can go into in looking at how women have contributed to our healthcare system. But this is just the overview I'm going to do. And then hopefully in the discussion, we can address some of the attendees, points of interest. So I'm just gonna get right into it here. Okay, when we look at history, there are many ways that we can tell the story of history, and these are the tools that are used to go back and tell a story about what has happened in the past that we weren't present for. So there are artifacts, autobiographies, diaries, documents, and storytelling. And mostly what I'm going to focus on is how the history of women's healthcare has been told mostly through the male voice, because women were not traditionally educated and were not literate and did not write and did not tell their stories, which is why I am very focused on encouraging women to tell their story in their own voice for posterity. So all human cultures still tell stories of the past, and they all do it in different ways. I mean, these are some. There are rock paintings that are being interpreted from civilizations thousands of years ago that we, are only now starting to try to understand. But for long periods of history, it was a written study. So cultures and civilizations that did not have a written language weren't looked at. And those who didn't write did not have their stories told. So one of the major populations who did not have their stories told were women accused of being witches. So this was a persecution that lasted over 400 years. The major persecution of witches was in Europe, although it did happen in colonial America. There were the famous Salem witch trials, but this happened mostly in medieval times in Europe. So before there was an understanding of science, disease was thought to be caused by either the devil or by God, and anyone that had skills to care for those with disease were thought to be possessed. Mostly these were women. Mostly they took care of a peasant population. They were persecuted mostly by men. They were persecuted for making and administering remedies, many of them herbal remedies with, an ancient tradition of herbalism. They were persecuted for providing expert care, which would have been learned by apprenticeship, for serving as midwives. If there were children born with any kind of anomaly, the midwife was accused of being a sorceress. And so the ability to heal and harm were completely interrelated. So because of this persecution, the wisest course for women were to try to blend and not be aggressive or assertive. And so this potentially, proud occupation, occupation that were practiced by women, it was either, obliviated or discredited. And because it wasn't the witch that was telling the story, her story was lost. There is no record of that. So I wanted to focus on healthcare in America. So what I want to talk about now is colonial America. So midwives came over there were midwives caring for women on the Mayflower when they came over, and they were the providers of healthcare for women in colonial times here. They were civil servants. They were respected members of their community. They were very much valued. They kept the social order. They were witnesses in trials at a time when it was culturally taboo for men to attend women in childbirth. This is a picture of a diary kept by a midwife from Hallowell, Maine. She kept a diary from 1785 to 1812, wrote in this diary every single day. It's the only written account of midwifery in colonial America. This diary was overlooked by male historians for years. And there was an incredible historian, Laurel Ulrich at the University of New Hampshire, who was told about this diary, found it, and I don't want to say analyzed it, but turned it into, interpreted it and turned it into an incredible story of what life for women was like during those colonial times. Martha Ballard was the first person to keep birth records in colonial America. There are accounts of delivery practices. This is how we know firsthand what delivery practices were like. She was the first to keep birth statistics. She recorded every infant birth, every infant death, every maternal death. She described women's contributions to the local economy. Describes the weaving and trading and baking and all that was done by women in those times that was looked at by male historians and thought to be a trivial account of daily life. But Laurel Ulrich just weaves it into this incredible story. So we have a really vivid picture of what her life was like getting to deliveries, how difficult it was for her to attend to women, how long the women stayed with other women after a delivery, how they cared for them and dressed them. It's really remarkable. She depicts how social healers were so closely identified with their communities, and which I want to get back to. There've been plenty of current studies that have been done that show how much better health outcomes are for everyone if they are cared for healthcare practitioners who are part of their community. Something that is pretty rare right now in our culture right now. So one of the quotes that I wanted to share that that Dr. Ulrich observed when going through this diary was that if history were learned from Martha's diary, it would be the doctors, not the midwives, that were marginalized. So when what we know of accounts of midwives' lives traditionally have been told through the medical or male voice. So this is really a remarkable account. So in the later 1700s to around 1800s, it was when men from America started traveling to Europe to get medical education. And they came back with some education about using forceps in childbirth and laudanum or morphine to medicate women in childbirth to address their pain. Because it was always, one of the things I always wondered was, when did it stop? When was that pivot from childbirth being a completely female realm to when was it that male doctors were introduced? And it was around the late 1700s when men started using tools in childbirth. Women did not use tools. They did not believe in them. And the men male doctors had poorer outcomes when they started attending deliveries. And their time spent with the women in labor was much less than the time that midwives were spending with women. However, as the population grew, it was harder and harder for midwives to attend, travel the distances to women's house, stay there for several days. And more women were actually requesting pain relief and a shortened labor. So I want to talk about, this is something that often gets overlooked when we look at healthcare and our system, is what the impact that midwifery and slavery had. So in 1808, it was outlawed to import slaves. So what happened with that was that even though they could continue to be sold and transported in the United States. So childbearing slaves became a means of producing more slaves. For this reason, African-American slave midwives were, they thrived because they were valuable. They were older, skilled women. They cared for their owners, their white owners, as well as for the slaves, because it was recognized how skilled they were. They facilitated communication between separated families, because the skilled midwives would travel between plantations. And then during Reconstruction, there were no other healthcare providers. So the midwives were the only ones providing care for that, for that entire population. Their community respected and valued them. Now I'm going to go through, so as medical, around that same time, I don't know why I can't see the top of my slide, but medical education was developing in America. So it was when the first medical school opened in Philadelphia. The more science involved in women's healthcare, the more intervention there was. And the more intervention, the more the maternal death rate increased. A lot of that because of hemorrhage and infection. So it wasn't until, was it 1880, that I think that the germ theory was, was discovered by Louis Pasteur. And so it wasn't understood how infection was passed. I'm going to highlight some women that had major influence in our medical system. One woman was Elizabeth Blackwell, who was the first woman to attend medical school in the United States. Okay, she was from an affluent abolitionist family. She was very well educated before she went to medical school. She decided to pursue an education in medicine when a friend of hers was dying of cancer, and lamented that she felt like she would have gotten better care if she had been attended to by a female doctor. So this motivated Elizabeth Blackwell to apply to medical school. She was rejected by 29 of the medical schools she applied to. As she had then applied to New York Geneva Medical College, where, as a joke, the administration asked the 150 male students if she should be admitted, and they all, as a joke, said yes. And that is the only reason that this woman got into a medical school. So she went. Obviously, it was a difficult situation, but she graduated. And then she opened a medical college for women in 1854. Her sister also became a physician. And between the two of them, again, very affluent, wealthy women, but between the two of them, they opened 17 women's medical colleges. Interesting, she wanted to be a surgeon, but when she was in medical training, she was caring for an infant and contaminated one of her eyes from an infant that had contracted gonorrhea from its mother, and was blind in that eye. So she wasn't able to become a surgeon. She then focused on medical education. Rebecca Lee Crumpler was the first African-American female doctor. Okay, she worked as a nurse in Boston for 8 years before applying to the New England Female College for Medicine. She spent her childhood with an aunt who cared for neighbors and became interested in nursing and medicine because of that. She wrote the first medical publication by an African-American, a book of medical discourses, which was basically a compilation of her notes taken caring for people, for women mostly. Florence Nightingale, I wanted to talk about. I had to learn about Florence Nightingale when I was in nursing school, and I guess very superficially in school, but it's very interesting to learn about the influence that she had in nursing. There were, she's sort of the matriarch of, or always learned that she was the matriarch of nursing. She also came from a very affluent, wealthy family in England. She wanted to study nursing. Her father was horrified because at that time it certainly was not a respected profession. It was not a trained profession. So she was sent to Germany, and she studied nursing there in 1851, and then led a team of nurses to the Crimean War in 1854, when she heard about the horrible conditions that the soldiers were dying in. Which, I think about that now. I mean, all these characters are so sort of cardboard cutout, in my head. And I just think realistically of what that must have been like to gather a team of other nurses and then head into an active war zone to care for dying soldiers. I mean, it really is quite remarkable. Because she came from such privilege, she was able to acquire funds to improve the hospitals that she was working in. And she raised the standard of nursing from uneducated, unsanitary sort of what she called camp followers, to a disciplined middle-aged group of women, but was very insistent that they were subservient to the doctors. Which when I think about it, her Victorian style of social norm in nursing was what caught on and sort of led the nursing culture, was the model for nursing culture, for evermore. Her legacy was basically of subservience and class bias. So a lot of the nursing training then emphasized character and not skill. So let's see. Susan Lafleche Picot was a Native American woman. She was the first Native American female doctor. She was from the Omaha tribe in Nebraska. When she was 8 years old, a sick Native American woman died at her side when the doctor failed to show up after being called 4 times to come. And this is what inspired her to pursue a medical degree, which obviously in 1889 was a difficult road. I mean, she also came from a well-educated family and had backing to be able to do that, but still pretty incredible accomplishment. Okay, so Mary Breckenridge, this is a woman who started the Frontier Nursing Service and midwifery service in Hyden, Kentucky. That started in 1925. So she was born in 1881, but to a very influential Kentucky family. Her father was a US ambassador to Russia. She was widowed at age 26, and she had 2 children who died very young. And after that, she decided to devote her life to improving healthcare for children. So when I was in midwifery school, she was held up as the mother of midwifery in America and revered. because she, started the frontier nursing service where midwives went out on horseback to care for these very poor women in Appalachia. And it's only recently that from her writing, again, want to emphasize how important it is for women to write their story, because we have a clearer picture of what her motivation was. She went to midwifery school in Britain, and then came back and tried to recreate the British model here. And she chose the hills of Appalachia in Kentucky, not for completely altruistic reasons, okay? When I learned about her, I was like, oh my God, that's just so amazing that she would just like devote such energy to caring for these poor people. Well, it turns out from reading her journals and writings, she chose that location because she wanted to improve the health of a racially pure population. So the nursing school and midwifery school there has deep roots in racism, which is something that my organization and me personally are reckoning with right now. There were no African-American midwives that were allowed to attend the school there. And it's to have chosen a group of people to care for based on what she considered their worthiness is something that I'm having a hard time getting my head around. So, my national organization, the American College of Nurse Midwives, it was always a big deal that she was the first to bring nurse midwifery to the United States. But there's been a reckoning as we read her diaries and see why she chose to locate her school where it is. I'll just read a quote. She considered them above average intellect and of, quote, the greatest possible value to a nation under attack by city-dwelling immigrants and African Americans. So in soliciting funding for this school, she played to these sort of racist fears and hostilities of the 1920s and 1930s. Maud Callan was a nurse midwife in South Carolina. She was orphaned at age 7. She was raised by an uncle who was a physician. She was college educated and became a nurse midwife and started a midwifery practice in her home. And in 1940, she started the Midwifery Training Institute. What is remarkable about her was how much the profession of nurse midwifery was highlighted by her 1951 being featured in a Life magazine photo essay. I included one of the photos here, but I really encourage you to go and look up this photo essay. They are amazing photographs of her life and work in rural South Carolina. What happened after this photo essay was published in Life magazine was that donations started pouring in to help her with her work. So after that, she was able to, with the donations, to open a clinic. Margaret Charles Smith was the granddaughter of a slave. She, very interesting life, this woman. At age 5, she was left alone with a woman in labor while someone went to call for an attendant midwife. And while she was alone there, the woman delivered. So she claims that she did her first delivery when she was age 5. She practiced midwifery in Alabama. She got educated. She was not college educated, but when there was a drive to increase the skill and education of rural midwives in the South, she did become licensed in 1949 and worked caring for her community until midwifery was prohibited and became illegal in 1976. She's co-authored a book called "Listen to Me Good." It's her story. It's an autobiographical story of her life in Alabama. So pretty incredible. See, I'm gonna have to hurry up. So I want to just address a little bit of how social changes have affected women's healthcare. So around the 1900s and in the early part of this century, for the first 20 years or so, there was huge social change, and the attractiveness of delivering in hospitals instead of home was attractive to many middle and upper class women. So there was the promise of, better care, safety. It was a time when women didn't have in-home help, and they would stay in the hospital for 2 to 3 weeks when they had a baby. Also, women were coming out of what they used to call labor and delivery and pregnancy, actually confinement. And it was a time when there was a more social awakening, and which was tremendously affected by the development of maternity clothes. So women did not go out in public because when they were pregnant, because they didn't have anything to wear. And then this immigrant dressmaker called Lena Bryant designed some stylish clothes for pregnant women that were bought by middle and upper middle class women. And that's where which is now the clothing line for larger sizes, Lane Bryant. So this is a time when affluent women wanted more freedom. They wanted shorter labors. They wanted twilight sleep, and they wanted to have pain relief in labor, where impoverished women were used more for experimentation and clinical experience by medical students. And then World War II happened, which led to decreased medical personnel in the hospitals. So women did not have the opportunity to stay for long hospital stays. In the 1950s, doctors became busier. They were less patient. They were not allowing women to labor naturally. It was a time when women didn't question medical advice, were pretty much did as they were told. And then licensing regulations changed rapidly until the 1960s, where every state passed laws prohibiting midwifery practice. And then the 1970s happened in the women's movement, where women started looking at their roles and standing up and protesting how they've been discriminated against. It was a time. This is the cover of Our Bodies, Ourselves. This was a groundbreaking publication where the Boston Women's Collective, a group of women, got together and realized, no one has taught them about their bodies. Okay, society had changed to the point where women weren't present at birth, so they were not learning about it just by being present, just culturally. And so a group of women got together and educated each other, and it was a huge time of social progress for women. And but still, this is still a time when midwifery was pretty marginalized, and the mainstream medical system was very doctor focused. And what happened then, another decade goes by, and in the 1980s, as insurance reimbursement changed, maternity care became a more consumer focused, and hospitals were shifting to attract more women for more income. And that is, not a lot has changed since then. So I'm gonna, I know I'm getting late-ish, but where we are now is, with all the strides made to increase awareness about women's health and how to provide that, what's happening now in the United States is the distances women have to travel to get healthcare that is respectful and dignified is becoming, further and further. Smaller rural health hospitals are not providing maternity care or women's health care anymore. And this is resulting in an increase in maternal mortality and poor outcomes for women. We're one of 8 countries in the world where the maternal mortality rate is rising. So I think what I want to do is, I know it was like fire hose information coming at you, but because, and I can continue, but I think what I want to do is maybe stop here and take some questions or see what kind of discussion we have. I have another slide, but I'm going to save it just in case we don't have enough time for questions, because we've only got like 15 minutes left.
Thank you so much, Linda. That was a lot of information. I put some links to books and so forth in the chat. If folks have any questions, we can go ahead and put them in the chat as well, or if you'd like to raise your hand, we can do that as well. And I want to thank Linda, because this was a lot of information, and yet this was a compilation of a wonderful Acadia Senior College course, is that right? And also a College of the Atlantic course that she presented. So it's a lot and important.
Well, I see Susan's got her hand up, but.
Oh, okay.
Okay.
Great, go ahead and you can unmute yourself. Let's see here.
There we go.
There you go.
Is it my turn?
Yes, please.
Okay. Linda, I think you referred in the 80s to insurance reimbursement changing. Do you have any background on how that, or why? That is such a big concept there.
It is. And it's changing all the time. And,
yes.
And as that changes, it's incredible how our insurance system now has influenced medical practice for women's health. And not in a good way at all. The more invasive, this has been shown in study after study, the more invasive healthcare gets, the poorer outcomes and the more expensive it is for women. So insurance is always kind of trying to save money on what they pay for. I'll give you an example. So for a cesarean section, we have an outrageously high cesarean section rate in this country. And it's just the next step after the forceps. So, male doctors started using forceps to expedite the delivery so it doesn't take as long. Okay, poorer outcomes. That moved on to cesarean section. Okay, so now that we have safer methods of surgery, it is much quicker to do a cesarean section than to let labor progress naturally. The more time you spend in the hospital, the more expensive it is. So this is, if we're talking about hospital birth. And, the more personnel that it takes, and hospital rooms are very expensive. So it is it's faster and actually ridiculously cost effective for physicians to deliver a child by surgery instead of letting labor take its course. So there've been all different insurance regulations. I mean, there was a time that if you had a previous C-section, insurance required you to have a trial of labors for your next baby. So because it would be cheaper for them to do a vaginal birth than a surgery. And then, when they do look at the cost-effective, analysis that they do, if it turns out that it's more cost-effective for them to do a surgery instead of having a trial of labor, you'll see that insurance regulations or standards of care will shift. So there've been, in the 40 years I have been practicing, we've gone from clearly demonstrated safety for women to have a vaginal birth after a cesarean section, clearly demonstrated, with the data that it's a safe option, to not being allowed to have a trial of labor after a C-section because their insurance, or because of insurance issues, and then which trickle down to then hospital policies. I mean, it's incredibly complicated because of money. And so, this is not okay. It's not okay that we are putting this kind of a price on women's lives. I mean, they're not looking at like long-term pain and discomfort for women that undergo surgeries that they don't need. And I maintain this is it's abuse. It's medical abuse of women. And it's happened throughout history. It's just changes depending on, what's culturally happening at the time. We have in midwifery, in midwifery schools, and circles, and in my, professional groups, we struggle a lot with trying to meld the art and the science. And it's a constant struggle to work within our system that has traditionally discriminated against women and female professions. And that's one of the things I wanted to talk about, professionalism. In order to gain respect within our system, there was a lot of pressure and focus on nursing and midwifery to become its own profession in order to, get on equal footing with medicine and to stop being, subservient. And I think it's my next slide. Yeah. So there's this professionalism versus, expertise. And what we're looking at now in our push to be professional, we're looking at how that has really meant that that professions that are caring for women now have become elitist and exclusive, sexist, racist, and classist, because it's so well demonstrated and supported that outcomes are better if women are cared for by members of their community, which means culturally, racially. And we have set up a system that makes it very difficult for those communities to get the education and the licensing they would need in order to practice within the system that we've set up. So midwifery especially is taking a long, hard look at that now. We're looking at, it became a very white woman profession. It wasn't initially, I think in 1920, there were like 200,000 midwives. When I graduated from school in 1978, there were 2,000. That's how good we were at systematically eliminating that profession. I know I've totally gone off on a tangent. Is there another question? Otherwise, there's a story I was going to tell.
Go ahead. I think that great to hear another story. And then,
okay.
And then
let me. I'm going to share this picture because when I moved on from, I left clinical practice. After 23 years here in Bar Harbor, but I had been practicing for 8 years before that. And it's interesting because it's a very demanding profession. It's very time consuming. It's physically difficult. You have to have a lot of stamina. It's hard to be up all night and then work all day. And it's interesting because when in the course that I was teaching, we really go through the Martha Ballard book, and midwives of that era, the colonial era, they did not start practicing until much later in life, after they had finished raising their children and could leave the home, or their children were old enough to take care of the home, because you had to have someone taking care of the home. So once I left clinical practice, I'm really interested at this stage of my life to pass this on. Okay, so I love teaching now. And so for the 3 years before the pandemic, I was teaching at a midwifery school in Malawi, Africa. And where it was very disturbing for me to see how we've imported sort of what I consider the worst of Western medicine. I was a Peace Corps volunteer in this country. It's why I went to midwifery school. I mean, I watched the midwives there, incredibly skilled, incredibly in tune with the women that they cared for, had incredibly good outcomes with almost no resources. And I go back 35 years later, and really wanting to be part of that system. And I found that, we had, like, the midwives there had, they were kind of behaving the same way we were. Like, their system had become hierarchical. Like the midwives were subservient to the doctors, and it wasn't like that when I had been there before. Anyway, I want to tell the story of this, what this picture represents, because their population has exploded. They're very short of medical personnel. So what the answer was for their Ministry of Health was to just admit a lot more nursing students to the program, but with relatively few faculty. So I was part of a faculty. There were 6 of us. We had over 300 students. It was ridiculous, really. And so we would get out to the clinical sites to supervise these students, pretty rarely. And on this particular day that I was with these 3 students, I had shown up onto a maternity ward, and there was a woman really writhing in pain and looking like she was about to deliver. And the students were just standing there. And I said, "What's going on? What's going on with this woman?" And they said, "Oh, she's about to go for a C-section." I said, "Why?" I said, "Because she's been here since last night and she hasn't delivered." And I went, "Well, okay. Have you examined her? Have you supported her? Have you, So I get the students together. We examine this woman. Delivery is imminent. And just then, the team of doctors come to take her to the operating room. And I turned to the doctors and said, could you just give us a half an hour? I really think we can deliver this baby vaginally. And they said, okay. They, there was no, I said it respectfully, and they turned around and they left, and that was it. And I looked at the students and I went, this woman can deliver this baby. We can help her get this baby out vaginally. So I was like, you're going to support her head. You're going to help hold her legs. You're going to encourage her to push. Anyway, a half an hour later, this is what the doctors saw when they came back. The baby was delivered. She had, her perineum was intact. She was breastfeeding her baby, and everybody was fine. She hardly lost any blood. And so everybody, they all turned around and left and were happy. And the students looked at me and went, we have never seen someone question the doctors before. And I just, like, the fact that I happened to walk onto the labor floor to be with these students at this particular time was luck. And I said to them, look at what can happen if we are just in tune with the women that we are caring for. Okay? You have the knowledge within you. It's just, we've got to be careful about becoming part of this system that doesn't work for women's best interests. Okay? And when we look at the cost of healthcare, and everybody's complaining about this, it's why maternity wards are closing in small rural hospitals, because, quote, they're too expensive. Okay? And as I reiterate time after time with students, respect is free. Dignity is free. We can reduce the cost of healthcare if we are just in tune and connected to the people that we are caring for. And it's a huge challenge because of the way our system is set up. But it doesn't have to be that way. We can bring back the more of the art of caring for women.
Wonderful. Thank you so much.
I know we're almost out of time.
That's all right. I think, unless anyone has any questions right now. No. Wow, Linda. Really, really important. Looks like we have one question here. Catherine, do you want to go ahead and unmute yourself?
Yes. Hi. Thanks. This is great, by the way. I had never realized that this country's death rate was actually on the rise. Can you talk about that for a minute? Like, why is that happening?
Okay. Yeah, I can talk about that. There are several reasons. The high C-section rate. So women are dying from complications from surgeries they do not need. Excuse me. And the access to quality healthcare. So when you look at our rural population, women are having to travel further and further and further to get their healthcare. And it's happening in Maine. There are all the maternity wards in the northern 2/3 of our state have the smaller hospitals have closed. So women are now having to drive 2 or 3 hours to get to a facility that will care for them. Okay, that is gender discrimination, and it is not acceptable. But that's what's happening. So fewer women are going to get prenatal care if they have to drive that far for their delivery. Many of these women are signing up for scheduled C-sections because they're worried about not making it to the hospital on time. They are then removed from their communities. They have the risk of dying from a complication from surgery is triple what it is in a normal birth. African American and Native American women die at triple the rate of white women because of the care or lack thereof that they're receiving. It's unconscionable. I mean, it is in Maine. I've been on a soapbox about this for a long time. I did a TED talk about it, that the argument that it is too expensive to keep a maternity ward open in a small hospital is gender discrimination. If a 55-year-old man shows up there having a heart attack, no one says, we don't do that anymore. You have to drive 2 hours to another hospital. This is the one thing in medicine that is never going to change. Women are going to continue to reproduce. And we should be able to provide that service within their community. So it is a huge challenge. I mean, because midwifery was nearly eradicated completely in this country, it's been really difficult to build that back up. So when I moved to Maine in 1992, I was the 9th nurse midwife in this state. Now there's over 100 of us, but okay, 35 years later, but most of them are concentrated in southern Maine. And so in the rural parts of the country, there are very few healthcare providers that will provide this service. So one of the things that I really am working on is getting a midwifery school in our state. So Hudson University has a program that that has every specialty of advanced practice nursing except midwifery. And so I've talked to the dean there, hoping that we can get a program started, because if women can, like, there are plenty of wonderful women that would be incredible midwives in these communities, in the places that have closed their maternity wards. But it'd be difficult for them to travel to go back to school. There are not that many midwifery programs in the country. So, you know, the thought is, if we can get midwifery schools closer to where we need the people in that profession, that we would be able to address this, you know, incredible shortage. Yeah.
Excellent. All right. Is there one more? Or is there someone I'm seeing? Susan, you had something else additionally? Oh, you're muted. Okay, hold on. You're still muted. Hang on, let me see if I can unmute you. Oh, there you go.
Yeah. The fact that women are not, that their viewpoint is not considered equal to a man's viewpoint. Their experience is not considered equal. Their take on a situation is not considered equal. I mean, this is across, I mean, as a mother, I remember, you know, decades ago with my children and talking to a doctor. I did not feel that a male doctor did not feel that my observations, that my experience with my children were considered, I would not say that they were dismissed, but they really were not given the same weight as the professional. And I mean, heavens knows I am not a doctor. I don't have that science background, but I did know what was going on for my child in that situation. I don't know how that barrier is broken, but I do. I mean, to me, it's rooted in, you know, in sexism, not that this is an original thought or anything. Go ahead.
And a lot of it is rooted in sexism and classism and elitism. So, you know, I hate to sound like I'm always doctor bashing. However, it has been part of the problem with the elite system that we have created. Mm-hmm. And there are, there's a need, look, hey, if I have a brain tumor, I want a brain surgeon that knows what he's doing. So, but what has happened is those super skilled professions are overused. Like we have medicalized a normal event and prohibited skilled, competent women from practicing to care for those women because we have, created a system of exclusion and elitism. And it's why I really encourage women to tell their story. Okay, it's just our voices need to be heard, and we have been socialized to believe that our stories aren't important, or they're not interesting, or nobody wants to hear it. We need to practice telling our story, writing our stories, telling our stories. We need to practice listening to other women's stories and valuing those stories.
Thank you.
Mm-hmm. Hear, hear.
That is a wonderful message to end on. Really, really important. And along those lines, on the International Women's Day, the actual theme this year is called Break the Bias. And it's about women and gaining more equality. So it's an important part of not just today, but every day. And having you with us today was fabulous. I really appreciate your time, your knowledge, and your passion.
Thank you. Thanks for inviting me.
All right, everyone. Thank you very much for joining us. We'll be recording this and I'll have it up on our website and on our YouTube channel in a couple of days. So if Linda and Susan want to hang on just a moment, we'll let everyone take off, and we will see you hopefully next time in 2 weeks for Encouraging Healthy Relationships. You can register online. Take care, everyone. Stay well.